Therapeutics Chronicles. I'm your host, Momen Wali, and today we are talking about a medication that every healthcare professional encounters, Tamsulosin. Whether you are managing patients with benign prostatic hyperplasia or looking at its off-label uses for ureteral stones, Tamsulosin is one of the most widely prescribed alpha blockers out there. On the surface, it seems like a simple medication. Take one capsule daily and the patient urinates more easily. But dig a little deeper and you will see that this drug has a lot more to it. From timing errors and drug interactions to a rather unexpected surgical complication. So let's break it all down, how Tamsulosin works, when to use it, and how to avoid common mistakes, and most importantly, how to catch mistakes before they catch you. Before we jump in, a quick reminder. If you are preparing for pharmacy board exams or just looking to sharpen your clinical knowledge, check out our Telegram and WhatsApp study groups linked in the description. If you haven't already, subscribe to the podcast and share it with your colleagues. I would also love to connect with you on LinkedIn where we can keep these clinical discussions going. Alright, let's get into it. Tamsulosin is an alpha-1A adrenergic antagonist that selectively blocks receptors in the prostate and bladder neck, relaxing smooth muscle to improve urinary flow. It is primarily used for benign prostatic hyperplasia, PPH, but also has off-label uses like facilitating ureteral stone passage. Unlike older alpha blockers like terazosin or doxazosin, which affect both alpha-1A and alpha-1B receptors and cause significant hypotension, Tamsulosin is uroselective, meaning it primarily acts on the urinary tract while sparing blood vessels. That's why it is preferred in normotensive patients or those who cannot tolerate the dizziness and hypotension of non-selective alpha blockers. The standard dose is 0.4 mg once daily, taken 30 minutes after the same meal each day. This part is critical. Patients often assume they can take it at any time, but taking Tamsulosin on an empty stomach significantly increases its absorption, leading to higher plasma levels and a greater risk of side effects, particularly orthostatic hypotension and dizziness. If symptoms persist and the patient is not responding well, the dose can be increased to 0.8 mg daily, but this also raises the risk of adverse effects. Speaking of adverse effects, dizziness and postural hypotension are among the most common complaints. Tamsulosin still has some alpha-1B activity, which means it can cause vasodilation, leading to orthostatic hypotension, especially in elderly patients or those who stand up too quickly. The key here is patient counseling. Advise them to rise slowly from a seated or lying position to reduce the risk of falls. Another major side effect is retrograde ejaculation, where semen enters the bladder instead of being expelled normally. It is harmless but alarming for patients who are not expecting it. So it is important to discuss this potential effect before starting therapy. Tamsulosin is metabolized primarily by CYP3A4 and CYP2D6, which means drug interactions can be a big issue. Potent CYP3A inhibitors like ketoconazole, clarithromycin, and erythromycin can significantly increase Tamsulosin level, leading to more dizziness and hypotension. Similarly, CYP2D6 inhibitors like paroxetine and fluoxetine can slow Tamsulosin metabolism, increasing its effects. Another key interaction is with phosphodiesterase 5 inhibitors, PDE5 inhibitors like sildenafil and tadalafil. These drugs already cause vasodilation, so taking them with Tamsulosin can exacerbate hypotension. Patients using both should be advised to separate dosing by at least 4 hours or start with the lowest dose of the PDE5 inhibitor. One of the most unique complications of Tamsulosin is intraoperative floppy iris syndrome, IFIS, which can occur in patients undergoing cataract surgery. Tamsulosin affects the iris dilator muscle, leading to poor pupil dilation and surgical complications. Here's the key takeaway. Even if a patient stopped Tamsulosin months ago, the effect can still persist. So ophthalmologists must be informed before cataract surgery. Stopping the drug before surgery does not necessarily eliminate the risk, so the surgical team may need to adjust their technique accordingly. Now let's put all of this into practice with some real-world cases. A 65-year-old male starts Tamsulosin 0.4 mg daily for PPH. A week later, he returns complaining of dizziness and lightheadedness, especially in the morning. A little investigation reveals he has been taking Tamsulosin on an empty stomach. Solution: advise him to take it 30 minutes after same meal daily. This stabilizes absorption, reduces peak plasma levels, and minimizes hypotensive effects. A 72-year-old man on Tamsulosin 0.4 mg daily is prescribed clarithromycin for pneumonia. 3 days later, he experiences severe dizziness and nearly faints. The likely cause? Clarithromycin is a potent CYP3A4 inhibitor, increasing Tamsulosin levels and exacerbating hypotension. The solution? Temporarily halt Tamsulosin until the antibiotic course is completed, then restart at 0.4 mg with close monitoring. A 58-year-old man on Tamsulosin for PPH is scheduled for cataract surgery. His ophthalmologist asks if he has ever taken an alpha blocker. What's the concern here? IFIS. He should inform his ophthalmologist about Tamsulosin use, even if he stopped months ago, so the surgical team can adjust their technique accordingly. A 70-year-old male on Tamsulosin starts sildenafil for erectile dysfunction. He reports feeling lightheaded and nearly passing out after standing up. The likely cause? Both medications lower blood pressure. The solution? Separate dosing by at least 4 hours and start with the lowest dose of sildenafil. Now, let's go over some key counseling points that must always be addressed when discussing Tamsulosin with patients. First, emphasize adherence to timing. Taking it after the same meal every day ensures steady absorption and minimizes fluctuations in drug levels. Second, caution about dizziness and orthostatic hypotension. Patients should avoid sudden position changes to prevent falls. Third, inform them about retrograde ejaculation. It is harmless but should be expected. Fourth, stress the importance of informing their ophthalmologist about Tamsulosin use before cataract surgery, even if they have stopped taking it. Fifth, review drug interactions, especially with PDE5 inhibitors, and recommend separating doses to avoid dangerous drops in blood pressure. Finally, advise patients to report any persistent dizziness, weakness, or symptoms that affect their daily activities, rather than stopping the medication abruptly. That's it for today's deep dive into Tamsulosin. If you found this episode helpful, subscribe and share it with your colleagues. If you are preparing for pharmacy board exams, join our Telegram and WhatsApp study groups. Links are in the description. Let's continue the conversation in our WhatsApp group for the Therapeutics Chronicles podcast community. And do not forget to connect with me on LinkedIn. I would love to engage in more professional discussions and expand our network. If you have any questions, thoughts, or future topics you would like me to cover, feel free to reach out. Catch mistakes before they catch you. Until next time, stay curious, keep learning, and always question everything. See you in the next episode.